Hello, everybody. I'm Heather Logan, the Executive Strategy Lead at CADITH, and I'll be your host today. I'm very pleased that CADITH is collaborating with Choosing Wisely Canada to present today's webinar about an exciting new initiative to curb the use of low-value lab tests in hospital settings. Before we start, I'd like to give you a territorial acknowledgement. I'd like to take a minute to acknowledge that CADITH staff work across the country, residing in various traditional lands and collaborating with Indigenous governments, healthcare organizations, providers, and community members. CADITH recognizes the inherent and treaty rights of all First Nations, Inuit, and Métis peoples across this land. We acknowledge the harms and the mistakes of the past and are committed to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Our Ottawa offices are located on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation. Our Toronto offices are located on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat. We recognize that the places where we live and work are home to many past, present, and future First Nations, Inuit, and Métis people. We acknowledge the deep significance of these territories and are grateful to have the opportunity to work and live on these lands. Wherever you are today, I encourage you to think about where you live and work and to give thanks to the Indigenous people who lived here before you and to those who still live there, and to continue to sustain and protect the land that we all call home. So we'll transition to an introduction of Using Labs Wisely initiative. It's hard to believe that Choosing Wisely Canada has been around for less than a decade. So great has been its impact in such a short amount of time. Choosing Wisely Canada is a national campaign that draws attention to low-value treatments and procedures and highlighting those that do more harm than good in certain circumstances. After issuing nearly 450 science-based recommendations on everything from allergy treatments to vascular surgery, Choosing Wisely Canada is now bringing its expertise and extensive clinical network to looking at low-value care in another area, lab tests in hospitals. Lab testing is the single highest volume medical activity. While most of these tests provide diagnostic insights that are important to patient care, not all tests are needed. Low-value lab tests can exhaust healthcare resources, lead to false positives, unnecessary follow-up, and potential harm for patients. So let me introduce you to your fantastic panel. For the next hour, you'll learn about Choosing Wisely Canada's new Using Labs Wisely program for hospitals, how it works, how to get involved, and how it will benefit patients, clinicians, and the health system. And our panel today, so Dr. Wendy Levinson, you'll see in the top left corner on your screen, will get us started with a short presentation about the Using Labs Wisely initiative. Dr. Levinson is the chair of Choosing Wisely Canada. She's also a professor of medicine at the University of Toronto and a national and international expert in the field of physician-patient communication. After the initial presentation, we'll hear from two additional experts with thoughts about the program and engage them and Dr. Levinson in a robust exploration of the program. Let me introduce them to you. So Dr. Janet Simons, just below Dr. Levinson on your screen, is a medical biochemist and an internist at Providence Healthcare in British Columbia. She's involved in both laboratory practice and clinical work in internal medicine, and she's a strong advocate for appropriate test utilization and high-value clinical care. Dr. Francois Belanger is the Vice President, Quality and Chief Medical Officer for Alberta Health Services. A key mandate of his position is to maintain a strong emphasis on the importance of quality and patient safety, engagement, leadership development, and relationships between medical staff and the health system. So welcome to all of our panelists and thank you for joining today. I have a few questions for each panelist to get things going after Dr. Levinson's presentation. So Dr. Levinson, I'll hand it over to you. Oh, as a reminder, let me do some housekeeping first. Please submit your questions at any time by clicking on the Q&A tab on the Zoom control bar. They will be visible to the panel members and to myself as the moderator, but they won't be visible to everybody. If you hear me consolidate questions and I'm not reading your question specifically as submitted, it's because we probably have multiple similar questions and I'll clump them together for a panel member to respond. We are recording the presentation and we will post it on CADITH's YouTube channel later this week. So share it and start a conversation, continue the conversation. And finally, and importantly, an evaluation survey will appear in a new window at the end of the presentation. Please, if you can take a minute, help us understand how to do better and to figure out what you're most interested in hearing from us and experts in Canada after this. So with that, now I think I'll hand it over to you, Dr. Levinson.
Hi, welcome to everybody. It's my pleasure to have an opportunity to tell you a little bit about Choosing Wisely Canada, and more specifically about the Using Labs program. So if you would turn to the next slide. I have nothing to disclose except that I receive support from Choosing Wisely Canada. Slide. So our vision is really to create a high quality, sustainable healthcare system for all Canadians. And really we do this through conversations between clinicians, patients, and healthcare partners to try to reduce unnecessary or low value tests and treatments and invest in high value care and make our system work best for our patients. Next slide. I want to start by explaining what we mean by an unnecessary or low value test. First, it's important to say that, of course, tests and treatments are critical to our healthcare system, and when they're needed, they should be done. We are really talking about the subset of things which really don't add value for our patients or can even be harmful. And sometimes people don't understand that harm can come from too much testing. That harm can be a test which is what we call a false positive. It isn't really positive, but it just statistically came out positive, and it leads to a cascade of other tests done to patients. Or it can lead to harm from excess radiation, or drugs can lead to harm from a side effect of the drug, even a life-threatening side effect. So things that we do in medicine should be thought about, considered, and when they're needed, of course they're needed, but if they're not needed, if they're redundant, then we try not to do them because we then avoid harm to patients. So in the next slide, I'm going to just show you a list. Our campaign is based on going to the national medical societies and asking them to create recommendations in their discipline for which there is excellent scientific evidence of overuse or harm to patients. So if you just click again, one of them will pop out, and I'll give you an example. This is the family medicine list. Don't do annual screening blood tests unless indicated by the patient's risk profile. That's because if we do a whole lot of tests on patients, we will find these abnormals just statistically. And if a patient is a young, healthy person, they don't need all these laboratory tests done that could do more harm than good. Next, just pop again. Here's another one. Don't routinely measure vitamin D in low-risk adults. So certainly in patients who could have a problem, we might want to measure them. But in many circumstances, we do vitamin D levels that for just kind of routinely, and patients don't benefit from it. And in fact, might get labeled as having an abnormality that really is not dangerous to them. So this is just an example. There are, like Heather said, over 450 of them, each with an explanation below it of why this is indicated. And these are distributed by the societies to their peers. And we, in many cases, have patient information in handouts to supplement this and explain the concept to patients. So the next slide. So if our original campaign, and when we started 8 years ago, was about stimulating this conversation about whether it's needed or whether it's not, now we've moved it really into trying to put these recommendations into action and to measure the impact. And so I'm going to give you one example that we've done already and then move to the next one, which is the labs. Next slide. So in the early part of the pandemic, in fall of 2020, we had a really serious concern about the blood supply in Canada because, just go back one, please, because we knew that blood was precious, and our donation rates in Canada fell because people were afraid to go in and donate blood, as you may remember. And so we also know that 30% of all the blood given, red blood cells, are really not necessary. They don't add value, and they can be harmful. They can cause side effects. And what's interesting is that many physicians like myself learned to write an order for 2 units of red blood cells instead of giving 1 and reassessing, or giving blood when it really was not needed. So what we did, and the next slide, is we created a campaign across Canada in the early pandemic to engage hospitals in measuring their blood use against two criteria, one related to whether they were giving 1 unit and one related to what the hemoglobin level was when they initiated the treatment. Therefore, was it needed? And we engaged the hospital community in this. And if they measured their own performance and then did quality improvement and maintained these benchmarks for a number of months, they could become a Using Blood Wisely hospital. And the next slide, you'll just see that, well, we have about 500 hospitals in Canada. We have about 216 participating. But what's important here is most of the big hospitals are participating. So there's over 70% of all the blood use is being incorporated into these 216 hospitals. And we hope that we're going to significantly decrease, in fact, we think we will, between 20 and 30%. So here's a precious resource donated by society. We need it when we need it, but we don't want it if we don't need it, because it does more harm than good. And so we hope we will be moving the needle on this. So next, I'm going to move to the labs, because this is the background of what we do. And now we've really shifted to focus some of our energy on labs in the hospital. So in the next slide, why did we pick this? Because as Heather said, lab testing is the single highest volume medical activity. We do spend a lot as a country on blood. We should spend a lot on laboratory testing, but we should spend it wisely. But we know that depending on the test, between 16 and 56% of these tests don't add any clinical value. And they, in fact, can cause harms that we've talked about, the false positives front, unnecessary follow-up tests and treatments. They can do direct potential harm, and they decrease our capacity to use the resources of the lab, the technicians, the laboratory testing materials on things we really need that add value for patients. Next slide. So it's interesting also that during the pandemic, there was, and continuing now, there is a worldwide shortage of tubes, the tubes that we collect blood in. And so this is a lot of press that came out from the Globe and Forbes and others about the shortage of blood testing material. And so we worked on the next slide with some of our medical societies who went through our recommendations. And you can pop one out for me. You'll see that they took our recommendations, and this one, for example, is in the inpatient setting. Don't order repeat blood counts or chemistry testing when the patient is stable. And they said, did you know that just one blood draw per day for routine testing can add up to removing a half a unit of blood in a week? And this results in 20 to 30 blood tubes and leads to anemia, which has a negative effect on patients. So in fact, doing these routine tests, and I can tell you, in an inpatient setting, we frequently just write an order, or there is an order that pops up that says, do a CBC and chemistry daily. And people forget that we don't really need it daily. We might need it the first few days, but if a patient is really stable, we forget to stop it because it just baked into our system that it's in the routine orders. So this is an example of a test that isn't really necessary and does more harm than good. Next slide. So with Janet's leadership and another internist named Adina Weinerman, we have created a program where hospitals, again, and it's hospitals, can join this collaborative. They submit their data, they commit to doing quality improvement, and they participate in a learning collaborative. And I'll let Janet tell you the level of incredible enthusiasm they have for learning from one another, because some of them are doing things very well and they have a lot to teach other hospitals. Next slide. And so just to give you a little bit of sense, especially for the clinicians on the phone, where I don't want to use too much medical jargon, forgive me, but there are tests, for example, that really don't need to be done in most settings in Canada, like a blood folate level. You may know we get folate in our food in Canada. And so having a folate level be abnormal is like really, really almost never heard of. except in rare circumstances that are where a patient has a problem. So we can eliminate certain tests really completely. Often we do two tests together when one test gives us the same information, and so that's in the second box. Or we do a test that's outdated, and the evidence have shown that there's a better test, like the tests at the bottom of this slide for heart damage, troponin. And then there are a host of other things like the daily labs we've been talking about, vitamin D, or something called a SED rate, which really, I think, the scientific evidence shows that they don't add value. Next slide. So really what we've done, and I'll turn it to Janet in a moment. We started with an initial cohort of 23 hospitals to pilot test this, see if we could get a real dialogue going between hospitals to learn from one another in Canada. We're now recruiting hospitals to start for a bigger cohort in September. And our goal is really to have a set of data, like what are the hospitals doing across Canada in these laboratory testing? How are they doing quality improvement? And how can we learn from one another to improve the quality of care, improve the quality, and prevent harm to our patients, and save the resources that aren't adding value to invest in high value care. So next slide. Lastly, I just want to say, we think a lot of this needs to be done at the grassroots with clinicians and patients, but also there is a very important role for policymakers, those of you on the phone who fall into this category, because there are systems barriers that drive overuse. I'll give you a little example that's not a lab, but it's pathology. It is lab, it's pathology lab. In many provinces, there is a public health act that requires doctors to submit any tissue removed at a surgery to pathology. So the orthopedic surgeons say to us, we don't need to submit the tissue from a hip and knee replacement. It's not done because there's pathology. We send it to the lab and it wastes resources and bogs the lab down. But we have to do it because the Public Health Service Act requires us. That's a system barrier that we need to work with. And so we really want to work with policymakers to figure out best ways to eliminate low value care, whether it's removing outdated tests that shouldn't be on the order form anymore, or building systems so the family doctor and the hospital know that the other one did that test already, so we don't repeat it unnecessarily. Sometimes we have a lot of gaps in our information system, or using criteria to say, oh, these kinds of patients do need this test, but if you're low risk, you don't, and can we build these criteria into our systems? So I'll stop there. I've tried to give you like a high level overview, and you'll hear a lot more from the other speakers, and then we can really get a discussion going. So you can move that slide down. You can just reduce that.
Thank you very much, Dr. Levinson. Now that we've got such a good grounding in the Using Labs Wisely program, I think we'll move on to some commentary, some questions. So as we do, I'm going to ask a question of some of our panelists. Please continue to put your questions into the Q&A. If you want me to address them to a specific panel member, let me know and I'll do my best. So Dr. Simons, I'm going to turn to you first. I think one of the issues that some people have been talking about and might be thinking about are, is this the right thing for patients? So as a clinician, as somebody who treats patients, what reassures you that implementing this program will not affect patient care or patient outcomes? How do you build confidence in this?
Thanks, Heather, and thanks for everyone for joining to learn about this really important program today. It's a really important question. I think that using labs wisely and everything that Choosing Wisely Canada does is really about putting the patient at the center of the decision making. And I know that those 5 lab targets that Choosing Wisely Canada has recommended for using labs wisely, plus lots of others, have really good scientific evidence behind them that, like Wendy said, these do not add value to the care of the patient, and in fact may be distracting or leading a physician down the wrong path in trying to sort out what is wrong with the patient. And so we are really, lots of clinicians are aware of this information, but like Wendy said, there are systems in place that just make it easier to order it anyways, rather than do what they know is right. So we're talking about educating patients and physicians about what is really low value so that everyone can have a conversation and be on the same page about that. And then also encouraging hospitals to put systems in place that make it easy to do the right thing for physicians to do the right thing for their patients. And so most physicians that I've talked to definitely recognize that these things that we're talking about don't add value or are not needed in every situation, but it's just easier to order them because once in a while you do want them and then you don't want to have to go back. So it's really about education and putting the right systems in place for things that we know that everyone is really comfortable with, and then having conversations for some people who are not aware of the evidence and just doing that kind of translational medicine. When I say translational medicine, what I mean is when there's really good evidence about something, but we're not translating that to the way we practice medicine. That's translational medicine, and a lot of Using Labs Wisely is about bringing forward that education so that people can translate what we know into what they do.
Thank you. So if I'm interpreting for people listening on the line, both your comments and Dr. Levinson's, this is about really thinking about what is best for the patient and making those choices, as opposed to not doing them at all. And I see both of you nodding your heads. Okay, terrific. I'm going to ask you one more question, then I'm going to build on a question in the Q&A box and turn to Dr. Belanger. So Dr. Levinson talked about 5 tests that are part of this initial launch of the program. Can you talk a little bit about how those particular tests were chosen? And what about the next set of tests? Do you stop here or do you do more?
Yeah, so the 5 tests that were chosen because they are things that, like I said, are generally accepted across specialties that do not need to be done in every situation, and that most physicians, if you stop and ask them, will concede that they do not need to be done every time. For example, those pairs of tests where 2 tests give you the same information as 1 test, or 2 tests that actually look for very different things have been combined. And 1 test is appropriate in some situations and the other in different situations, but you don't need to order them as a package. We've just packaged them historically. So these are things that we think are relatively, everything has a little bit of contention to it, but relatively uncontentious, and that really have just sort of been passed down through generations of sort of medical. This is how we do this, just sort of kind of just so, I call them medical just so stories. We do this just cuz. And just sort of challenging some of that ingrained, we just do this because that's what I was told to do, as opposed to I understand why I'm doing this and it's for the best interest of the patient. So those are those 5 what we call quick wins, low hanging fruit, although the fruit is often not that low and the win is often not that quick, but they are relatively straightforward targets. There are lots of other targets that we alluded to, like our daily repeating labs and vitamin D testing, that some of our hospitals that participate in our learning collaborative might also want to tackle, and we support and we encourage that. So this collaborative is not focused just on those 5 things. We're trying to track those 5 things across the country to help share data and help people benchmark against each other, but we are not limiting people to doing one of those 5 things. When we did our initial pilot program, we learned that many of the hospitals had done some work on at least one of those 5 things, but that there was some hospital somewhere that needed to work on each one of those. And so even something like the CKMB, which I was honestly surprised that there's any hospitals in Canada still running that. We're learning that, yeah, there are some hospitals that for historical reasons, for reasons of individual personality and practice patterns, haven't been able to eliminate that test, even though it's been eliminated in the vast majority of hospitals across Canada. So we can support those institutions by sharing data, by showing the information that other sites are not doing this, it's not affecting patient outcomes, and collaborating with each other. And so those 5 tests are really what we think are relatively uncontentious, straightforward, and just need a little bit of extra push and collaboration due to individual sort of historical factors at each site.
So thank you for that. I'm also hearing in both your presentation and Dr. Levinson's that given the number of hospitals and the extent of interaction between them and the data collection, there's lots of opportunity to hear if something needs to be heard. If there's a need for a correction, you'll hear it. So you've got those safety mechanisms kind of built right in. I'm going to turn to Dr. Boulanger and think about questions from a patient perspective. So I'll read one of the questions that has come in, and then I'll ask you the specific question. So how do we educate patients on this? While physicians may understand why routine testing isn't necessary, and it sounds like part of this program is also there to support physicians in some of that thinking, patients may feel they're not receiving the test they need and are used to receiving, especially when these 5 are tests that we're talking about doing less of. So how do we empower patients and providers to choose, be aware, and to choose evidence-based, informed conditions or decisions? Dr. Boulanger.
Yeah, thank you so much, Heather, and thank you so much. It's really a pleasure to be with distinguished panel members and having this discussion today. So I think, what we've done, I'll tell you what we've done in Alberta with across 105 sites and with our patient advisors. We have a patient-first strategy that is really emphasized on co-designing the health system together and co-designing how care is provided. And that's what we do with patients. So what we do is we engage them in conversations like this about unwarranted or low value lab testing early on in the process. And it's not just a matter of educating them, it's a matter of involving them in the decision making. So what we've developed a program called Right Care Alberta. Right Care Alberta has 3 components. One is clinical appropriateness, so all the initiatives related to lab and others, and we're using Choosing Wisely as a standard and rolling them out within Alberta Health Services. The second component is shared decision making. I think that's where the conversations do occur between providers and patients in terms of what are the goals for that particular patient, and then align the investigations, lab investigations or other treatments in order to meet that goal. And that's been well shown in programs, for example, in Scotland, where with realistic medicine, it's shown to actually eliminate low value testing. And the third component is actually an atlas of variation. We're developing an atlas of variation. Other jurisdictions have done that, and actually publicly release the atlas of variation, so it engages the public into the patients into the conversation. So it occurs very much at the local level between a provider and a patient, but also the system level and the culture that you create in terms of really co-designing or co-creating the health service delivery. Thank you.
Thank you very much. I think we'll stay on the topic of patients for another few minutes. And Dr. Levinson, I'll turn to you and just say, can you give the audience an understanding of how patients are involved in the work of Choosing Wisely? And in this particular, was there an ability to factor in the perspective of patients about what is and isn't a valuable lab test?
So, I mean, first of all, we try to engage. We have patients on our core team. So we meet weekly, and there are 2 patients who are part of our core team. Plus, we have a more broad patient advisory panel that we can draw in different efforts. I think some decisions are a lot driven by patient preference, like antibiotics, discussions about imaging. Some of the lab tests we're talking about are really sort of more technical. And like Janet just said, sometimes we are doing an outmoded test like the CKMB when troponin is a preferable test. That is probably a less patient-driven kind of choice than the lab not knowing or the physicians not transitioning for some reason. So I think, it's fair to say that some things really do require a lot of conversation, but probably a patient doesn't care if we're doing a CKMB or a troponin because that's not really a patient-sensitive choice. That's more a laboratory-sensitive choice. So some of our testing is patient-centered, like vitamin D levels, where patients might come in requesting a vitamin D level. And we try to teach patients to have these conversations. We give patients 4 questions. Do I really need this test or treatment? What are the downsides? Are there simpler, safer options? And what if I do nothing? And so we encourage patients to ask those questions of their providers. And for many of these laboratory tests, they're useful and helpful. Some of them are more, I think, doctor-driven kinds of decisions, like between the internists or the surgeons and the lab person like Janet to decide what's best in a hospital. But we really try to imbue. I mean, I want to bring up one of our patients, Cindy, she kind of says to us all the time on the daily laboratory testing that happens, but wait a minute, I've just been in the hospital and they wake me up at 5 a.m. to poke me. Please don't do that if it's not needed. So I think there are many patient perspectives that are critical to this.
Thank you. I'm going to switch to the policy systems level now. Dr. Levinson, you introduced this with some examples at the end of your presentation. So the question is for Dr. Simons. Creating change in the Canadian healthcare systems landscape and in clinical practice can be really hard. We've heard the number thrown around for years that it can take often 17 years from evidence to change in practice. That's a long time. Why did Choosing Wisely Canada recommendations really resonate with physicians? What is it about what they're doing and what you're doing as a physician leader that makes physicians stand up and say, I'm part of this?
Thanks, Heather. I think that really what it is, there's two things. One is that the recommendations are both simple, yet very clearly supported by evidence. And the second is that a lot of the Choosing Wisely Canada recommendations, or in fact, all of them, are coming directly from our specialty societies. So this is not bean counters in the provincial level telling doctors what to do. This is the society representing that specialty of physicians saying, we recognize that there's evidence that we're not using these tests well, or that we have opportunity to be more specific about how we order these tests. And they're putting those down as recommendations. So this is not, this is really physician driven. And clinician driven, because I know our nurse practitioners also have recommendations, our midwives also have recommendations. So this is really about the people doing this, advocating for ourselves to be better, as opposed to someone coming down from on high telling us you need to stop doing as many tests.
So it comes from a history of education and medicine and understanding where you can really have an impact. Thank you. Dr. Belanger, I'm going to turn to you as both a physician leader and an administrative leader in Alberta Health Services. Of the many things that you could focus on in a system, tell us why the Using Labs Wisely program is important in your jurisdiction. Why is it important to focus on?
So I'll just give you an example. We're in a process of implementing our clinical information system across Alberta Health Services throughout Alberta. And through one of our site, we use a clinical information system to support best practice in clinical decision support. And we reduced, just at one site, number of tests by 20,000 in 1 month. And that corresponds to a savings of $2 million a year. So first of all, it's better patient care. I think at the end of the day, and Wendy mentioned this, more testing is not necessarily better. It leads to potentially patient harm, similarly to under testing. So, I think that's really important. And second is there's an opportunity cost here. There's limited funding in healthcare, and we have a duty to actually do the right thing in terms of funding. Why should we fund low value testing while we could actually use those dollars and fund high value testing and high value interventions that are evidence based. So, I think those are kind of the examples that we're using internally, and we're using Choosing Wisely broadly. That's what we did, and we're using our clinical information system to make Choosing Wisely effective. And for all the reasons mentioned, there's strong engagement on the part of our clinicians and frankly, patients as well.
Thank you. So I'm going to bridge from a question that's been in the chat and we've seen in social media, and we've probably read in just the more standard media, that the pandemic has caused a number of procedures, tests, interventions to be, in some cases, very substantially delayed. Do you see, and I think I might turn any of you panelists if you want to respond to this, do you see Using Labs Wisely and
Is it Heather that froze or me?
It's Heather.
Okay.
Apologies.
We have her back again.
So I don't know how far I got on the question before I was cut off, so I'll start again. We've seen in social media and in media, and I think we've all read reports that because of the pandemic, a number of interventions and tests have been, in some cases, very substantially delayed. Do you see things like using labs wisely as a way to help remedy some of those delays in the system? And I'd open it up to any panel member.
Well, I'll just jump in, and then I mean, I think Francoise, it'd be really useful to hear from you at the Alberta level. I mean, obviously we need to help patients get the care they need, especially if it was delayed. But I think the point is that we have to free up the resources. Like, if we have people like Janet, who runs a lab, having to be under so much pressure to do work, let's get her to do the right work. Let's get rid of some things. Like, I learned from Janet and the lab program that a test that I used to order all the time, called a SED rate, takes a bunch of time for a technician to run it. I would prefer that Janet and the lab folks use their time to take care of those people who are in the backlog, to do the tests they need. So let's help her out by not ordering a SED rate that I used to order that doesn't add value, and free up capacity in our system. And I think we've learned that there's a real pressure on the health and human resources in the laboratory sector who are needed to do these things. So I don't know, Francoise or Janet, from your perspective, how do you see this?
Well, the challenges we've had is with the pandemic is, first of all, there was a tremendous amount of resources that were dedicated to testing. And so that, we had to prioritize that activity. Then the other issue is the workforce. The workforce gets sick, and like in all hospitals across Canada and across the world, we experience issues about the workforce, and that's certainly, affecting the lab as well. So we've had to prioritize our activities in terms of the lab, and I think that's a very useful exercise, because if you can get some of the data, on unwarranted variation, if you can get the data on tests that are low value, then you can prioritize your activities. And I think that's what's been fortunate. Now, there's a fine line, because if you prioritize certain areas, and maybe others that if you have to do too much prioritization, there might be and we all know there's an impact on the care gap. So I think choosing Wisely Canada has been really effective, because at the end of the day, it's a movement. Right? It's a movement by providers and patients to do the right thing in terms of patient care. And I think it's not threatening. And I think that provides sort of the basis that helps us in discussing things with clinicians, for example, when we have to actually have discussions about what we prioritize or do not prioritize. Thank you.
Dr. Simons, is there anything you'd like to add to that?
No, I mean, I would echo definitely that one of our challenges in the lab during the pandemic has been both human resources and physical supply resources. And so, anything we can do to minimize unnecessary testing helps us prioritize the stuff that really does need to happen. And then the other thing I was going to say is, sorry, I just lost what I was going to say. No, but I agree that, the other thing I was going to say is that this is not Choosing Wisely Canada or any organization telling hospitals what tests they need to do less of or to stop offering a certain test. It's about offering a national collaborative where we can have these discussions, and then each organization that's in the program gets to pick what makes sense for them locally. So what makes sense for their physicians and their patients, and then they will also be able to choose how they redirect the resources that they might be able to save to best serve their patients and what they've been needing. And so this is not, a bean counting exercise. This is empowering each local organization to do what they think is best for their patient population.
Thank you. There's a couple of questions in the chat, and I apologize to those of you on the line who have previously submitted questions when I was disconnected from the system. They all disappeared. So if you'd like to repost them, I'll do my best to answer them. But there are a number of questions that have come in now around cost. Now, I know this is going to be a sensitive issue, and we're not afraid of talking about tough issues. They're important, and patients and clinicians and system administrators have these questions. So I'm going to pose the question, and I think turn to Dr. Levinson first, and then Dr. Belanger. So the issue of opportunity cost. If you do one thing, it's difficult to do the other thing simultaneously, and so you have to make choices. Do you think there's a value in communicating the cost of these tests so people understand the impact on the system? And I wonder if you could reinforce, is this about cost, or is this about better patient care? Dr. Levinson, can you address that first, and then Dr. Belanger?
Sure. So, I mean, really choosing wisely Canada is about care, high quality care and harm prevention. Let me just go back to the example of blood. Here we donate blood. It's a precious resource. It has side effects for patients. It does cost $1 billion a year in Canada that we spend to buy blood. That doesn't include all the costs of crossing and typing and hanging it. So if we know that 30% of those red blood cell transfusions are not needed, that the patient would do equally well, and the science, really strong science demonstrates that, then why would we waste a precious resource, cause potential harm from side effects, and have the cost? So decreasing that kind of thing is a win-win-win. The cost is not the driver here. It's quality of care and preventing harm. And in some cases, it will also save money that can be reinvested in high value care. So I think what I always say, doctors and patients don't get up in the morning to save money for the healthcare system. We want to deliver the best care for our patient in front of us. And that's why these recommendations resonate with doctors and patients, because they make sense clinically. And in some cases, like the blood example, we could save money.
Thank you. Dr. Blanchet.
I totally agree. I think that, you know, and our journey on this is really based on the quadruple aim. And, you know, so better for, you know, what improves our population outcomes, what is important from a provider's perspective, because they are key into this, patient experience, and also the cost. So you know, so this is about quality of care from my perspective. It's about better health outcomes, about quality of care. And of course, you have to have the cost conversation about it, but it's first of all, if you sell this just on the basis of cost, it's not going to work either with patients or with providers. So it is about quality of care, and it is about doing the right thing for patients. I think there are two big problems we're having is the use of low value investigations, including lab, and then unwarranted variation in the care that we do. I think, you know, there's really some variation is obviously desired and necessary, but you know, I think the gap in terms of the variation is too broad at this point in time, and this is something we need to address. Thank you.
Thank you, Dr. Levinson. I'm going to ask you two questions. The second one will be where hospitals should go to be part of the program, because if people are on limited time, I want everybody on the line to know where to go if they want to sign up to be part of the program. The first question, though, also is a little bit potentially controversial. This is a hospital-based program. Can you talk at all? Do you have a view or a vision about potentially expanding this into communities? A lot of patients receive lab tests in the community.
Mm-hmm. So in terms of the sign up, if you just go to our Choosing Wisely Canada webpage, you'll be able to sign up for hospitals that want to sign up, or you can email and either me and Janet. And I was hoping at the end we could just give you our email addresses, because I noticed there are quite a few questions that Janet are on specific lab tests, and maybe we can answer them offline if we can get addresses for people, or they can send an email to us. So you could sign up. We hope to do work in the outpatient sector later. It's a more difficult, you know, sadly, it's a little more difficult to work in the outpatient sector. For example, if we wanted to work with family doctors and work on this, there are lots of family doctors practicing in many different settings. And so it's more challenging, and we're a small group. So we did start in the hospital setting. We hope ultimately we can move into more of the outpatient setting and work with the community laboratories on this also, but we're not there yet.
Thank you. Dr. Simons, I'm going to turn to you now. We've had a bunch of questions come in about medical students and other allied healthcare professionals, but can you help the audience understand a little bit about how do you get this information into medical students so they don't have to unlearn anything?
That's a fabulous question. Yeah, I really want to know that too. It's one of these things where there's a curriculum in medical school, and then there's what we call the hidden curriculum in medicine, right? So most of these things are not programmed into the current formal medical curriculum to an extent, perhaps, but you know, we learn about what tests can do and what conditions we might want to order them in medical school. But what we learn that's not in the curriculum, that's in the hidden curriculum, is what you should be doing on the ground. So when you go see a patient and you haven't ordered those labs, your senior resident or your attending says, why didn't you order this? We always just order blah, 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 and well, we just do it in every patient because it's easier that way. And then you learn that as part of the hidden curriculum. It's not part of a formal, this is what you're supposed to learn when you exit medical school. And so how do we challenge that hidden curriculum? It's really about getting that education through every level, right? Because the hidden curriculum comes from the layers above us. And so it's easier than it sounds. No, it's easier said than done to just not teach medical students to do this, because it's coming through that sort of apprenticeship model of medical education through all of the levels above them. What we can do, I think, is go to the medical schools and arm them with this information, arm them with the recommendations and the evidence behind them, and teach them to ask why. That's what I always, when I have medical students or residents with them, I say always, if you don't understand why I've asked you to order something, I need you to ask me, why did I say that? So that either I can be corrected because I'm doing this on autopilot and I actually don't need that test, or I can teach you something about the indication. And so I think it's really creating this culture of questioning, and why are we doing this? Is this the right thing to do? And imbuing that throughout all the layers of medical education.
I may just
Terrific.
jump in for 1 second. The students themselves across the 17 medical schools in Canada started a program called Choosing Wisely STARS, which stands for Students and Trainees Advocating for Resource Stewardship. And we've empowered these students, tried to work with them so that they can go back and embed some of this in the curriculum of their medical school. So there's kind of an army of students. I actually think students know about it more than a lot of the attending physicians, because there's kind of been this groundswell bottom up of interest of the trainees.
That's one of the things I have to admit I didn't know enough about when I heard about Choosing Wisely Canada the first time, was how much of this is the groundswell, how much of this is people in patient care environments actually saying we need to do these things. Very powerful. So I want to call out, there's a number of comments here to say fantastic presentation, great work, Janet, great to see health system leaders focusing on these kinds of things. So just, I want to acknowledge that on the call. I'm going to ask a question to you, Dr. Belanger. We talked earlier about the many things you could do and why choose this. Building on that, what are some of the barriers that you might imagine people in positions like yours, administrators, leaders in health systems, might face in trying to advance this kind of work? And what lessons maybe have you learned to help them?
Yeah, thank you, Heather. Great question. So, I think first barrier we talked is about the culture. I think you need to set the right culture as an organization, being a learning organization. I think that's critical, and have a platform as we have in the quadruple aim to move this forward. You need from my perspective, I think, provincially, you need a bit of a balance between the grassroots movement of this and the local level improvement and what is done provincially, so that you can have the biggest impact. So we have a team that actually is just focused on this provincially. So, they're catalysts. They are there to gather the initiatives, local initiatives, see what we can spread and scale, see where the biggest impact can be, organize the information, and drive the initiatives from a project perspective. So I think that's critical. Now you need to have a real kind of disciplined project management approach. The third part is have a really good analytics system, because you can't measure what you can't improve, and you got to be able to feed back the data to the providers at the front line and show them throughout it and feedback what the data is. And you got to incorporate the best practices and the clinical decision support within your clinical information system. That's key in terms of driving the improvement as well. So I think that's critical. And then the third part I would say is partnerships. So we talked a bit about, partnerships in the community, and definitely need that, because a lot of the investigations are ordered by family physicians in the community or specialists in the community. So you need to be able to partner with our physicians and colleagues in primary care. And I would say also the regulatory colleges. The regulatory colleges have a role in this, in setting up the expectations in terms of a quality program for physicians. I think that's critical as well. And I would say that at the end, also, the last part is getting a change management. The other barriers to overcome is a change management system. So you need to be able to take the data, go through audit and feedback, yes, provide clinical decision support, but there has to be that realization at the provider level that, okay, and now I've got the data, here's my change management plan, and this is my monitoring plan. And it's got to be some accountability and governance around this. That is not done in an intimidating way or disciplinary way. It's got to be done in an engaging way so that we can improve care for patients. So a bit of a long-winded answer, Heather, but I think it gives you kind of the perspective of the health system. Thank you.
That's terrific. Thank you. I know there are people on the line who are in leadership positions and might be thinking, where do I even start? So that's a great answer. I'd like to build on that. There's an individual who's submitted a number of questions that I think Wendy and Janet, you might want to follow up with, because they've raised questions about specific tests. But here's a more general one for you, Dr. Belanger. So I'll read the bit at the beginning and then ask you the question. In the 1970s, it was relatively common for medical students to draw blood or other samples, for example, swabs and cultures, and even to visit the lab during their training. This is now rare or non-existent, apparently. Nurse practitioners and nursing students also don't seem to get any exposure. Do you know of it, whether routine exposure to lab environment or seeing how tests are processed and the time and energy it requires is of any value in helping to rethink what's necessary and what's valuable in lab testing?
Yeah, it's a really great question. I'm one of those older physicians that had to do the blood drawing and the IVs all by myself. And you become really attuned to what you really need quickly. And I think that's actually a really important question, because what happens now is, hey, you open up a panel and you see you have all the tests at your disposition, and you tend to order more than what you should. So I think, how do we configure in a clinical information system, in the clinical information system world, how do we configure our order sets, and how do we, translate that into practice is really, really critical. And how do we, there was a discussion about the medical student. I think it starts there, because at the end of the day, a lot of the tests are ordered not just by medical students, but our residents. They're the one they're ordering a lot of the investigations, and particularly in the lab side. And so I think getting them involved early on about the various concepts of, right to the right test for the right patient at the right time is really critical. And then also the concept of, there is choices to be made, and really not focusing on high value investigations rather than low value investigation. I think getting that education on would be, for me, get an education platform would be the first step. I think there is some value though in having providers experience what it is to draw blood and the impact that it has on patients. I think that's really important, and I think we probably lost a little bit of that over time. So it's a great point. Thank you.
Thank you. So this is a resubmitted question. And so I'm going to ask either Dr. Levinson or Dr. Simons to answer it. So I'll read the question, and you can just jump in whenever you feel like you'd like to answer. There's no question that there are a ton of tests that are being done that are not necessary. The problem can be that while decreasing a test frequency makes statistical sense and clinical sense for a whole population, there might be individuals that a traditionally routine test would pick up a clinically significant abnormality earlier, and I think by extension then mean that treatment might be more effective or different options. How do we reconcile that?
I think that, the question is really about how do we be more specific with our choices, right? So as opposed, one strategy is just order everything on everybody and accept that there's going to be a lot of noise, and you might lose the signal in the noise because the bicarb is often a little bit abnormal and you're not going to pay too much attention to it. But you know that in some patients you want to pay attention to it. Well, if you know that in some patients you want to pay attention to it, those are the patients in which you specifically order that test, and you don't order on everybody. So right now, or in a lot of people's practice, you order routine testing on everyone, and then you have to be very thoughtful and specific about how you interpret those tests. We're saying we've generated a lot of waste, we've generated potential patient harm if we don't interpret those things correctly. If we're more thoughtful and specific about how we order the tests, then we eliminate waste, we eliminate patient harm, but we can also, make sure that we are catching, if we're worried about GI bleed, maybe you do want the urea on that specific patient. If you're worried about, respiratory failure, maybe you do want the bicarb on that specific patient. That doesn't mean we need it every day on every patient. So it's really about changing our lens around specificity, not in how we interpret them, but in how we order them.
I think it's about clinical, I completely agree. It's about clinical decision-making. It's using our knowledge about the pre-test probability of a disease in a particular patient and tailoring, because we're not blankets. We should be tailoring to the individual patient. But then I'd add, and then there's some tests that just don't make sense. So, hemoglobin A1C, for people who are not physicians, it's a measure of diabetes control, but it changes every 90 days. It takes about 90 days to change. So there is no point in ordering a hemoglobin A1C 1 month after it was just done. It's not going to change. So some things in our system we need to change for everyone, because they just don't make sense. But for other issues, it's really about clinical decision-making, like Janet explained.
So I cannot believe how fast that hour went. That brings us to the end of today's session. So I want to thank Dr. Levinson, Dr. Belanger, and Dr. Simons for sharing their insights for this really exciting new program. We'd like to hear more about it after it's been in operation, so I hope you'll come back maybe next year and do a follow-up, but we're sure it's going to be a big success. And finally, to all of you who've taken time out of your day to join us today, we hope you found it informative. I think there'll be a couple of follow-ups to people who've asked about specific questions, so hopefully that's of value to you as well. And remember the evaluation survey. Before we go, though, I'm going to turn to each panelist and ask them to give us their final word. If there's one thing that you want people to remember from today, what's that? And I'll start with you, Dr. Levinson.
Well, I think this is about a culture change. We've lived in a society where more is better. And what we're trying to do with doctors and patients is be more thoughtful about decisions. So we order what's needed, it's the right care at the right time, and we reduce the things that aren't needed or even are harmful. And so actually, I'd encourage each of you, either as a patient or a clinician, or both, because we're both, to have these conversations, stimulate these conversations in your settings. Thanks for sharing.
Dr. Belanger, I'll turn to you, and I've chosen, Janet, I'm asking you to go last because you're at the interface with patients every day, and I'd like you to have the last word because you've got that patient-facing perspective. Dr. Belanger.
Yeah, for me, it's actually bringing this down to the level of the patients and having a true conversations with patients that is, bilateral and takes their thinking and their goals in mind. So really, the co-design piece is really important for me. And the second piece is we need to design the system so that it can produce the results that we want to produce. And I think that's key in our journey. Thank you.
Dr. Simons, over to you.
Thanks, Heather, and thanks for giving me the last word. I'll echo what the other two said. This is really about empowering physicians and patients to know what the right thing to do is and to be able to work in systems that let them do the right thing easily. So this is about making sure that we are, spreading education and data to inform decision-making and then making it easy to make those right choices. And I'm really excited to be part of it.
All right, thank you. That draws us to a close. Please fill out the evaluation. Join us next time, and thanks again.
Thanks, Heather.